Speaker. Today our topic is delirium. Our speaker, Dr. Grishma S. Nair. She's currently serves as a palliative care senior palliative care physician at Palliative, India, and she had completed her MBBS from SUT Academy of Medical Sciences, Thiruvananthapuram, and she holds certificate of CCPPM from Palliative, India. She is actively associated with ECHO India, Life with Dignity, and other key palliative care initiatives advocating mute of PAL and community-based care models. Her areas of interest include early integration of palliative care, geriatric care models, and training healthcare professionals to deliver compassionate end-of-life support. Welcome, ma'am. Welcome for this session. Dear participants, if you have any doubts, please put it in chat box.
Thank you, ma'am, for the kind introduction, and good afternoon, all of you. So today's topic is delirium. Can I share the presentation?
Just a minute, ma'am.
Okay.
Ma'am, I didn't get your PPT. Sorry, Hannah.
I will share it from here. Is that okay? I can share it from here.
Sure, yeah. Definitely, ma'am, you can.
Okay. So, is it visible for all of you?
Yes, ma'am, it is.
Yes. Okay. Thank you. So I hope I am audible enough. So today's topic is delirium, right? So please go through this case one. This is a scenario. Mrs. Y, a 72-year-old woman with advanced cancer, was admitted to the palliative care unit for symptom management. She was previously alert and oriented, but suddenly became restless, started making incoherent speech, and had difficulty recognizing her daughter. She seemed frightened, kept trying to get out of bed, and was convinced there were strangers in the room. Her symptoms fluctuated throughout the day, and sometimes she appeared calm, but by evening she was more agitated again. So, I'm going to the next scenario. I hope you got an idea, right? Next, Mr. X.
I'm sorry to interrupt. Can you make it bigger screen? Because it's small. So it has two slides.
collaborate together to create a hospital impact. I think we are missing something. So to start,
The participants, is this visible for you?
and now let's
I think most
hear
of them are
from
using
the
mobile phones. So
clients, dining high impacts, are started.
Wait a minute.
Start, let's go ahead.
Something is disturbing.
Are you not able to see the slide?
Yes, ma'am.
Is it okay or
yes, ma'am, but it's small. So we can see two slides.
so small?
Both
Okay.
people can
Ah.
see it before.
Okay, Malik, please come.
Most of them are using mobile phones, so maybe they'll face some issues with the screen. So, dear participants, please respond. Is this clear or
Dear participants, please unmute your mic.
By the process. So I know
How is it now? Is it the same?
yes, ma'am? But I think we can continue our
It's okay, ma'am. You can continue.
yeah, we can continue, ma'am. It's fine. Sarita, is it fine?
Okay, we will correct it, but I'm moving on to the next slide since the
Yeah,
time is moving on. So the case 2, Mr. X, 65-year-old man diagnosed with carcinoma of lung, who is on morphine for his pain. His caregivers reports to you, patient frequently talks irrelevantly, but at times he is very clear. They also said that patient is sleeping more in the morning hours compared to night. The problem developed 3 days back. Okay. So here also you can see a 65-year-old man. He was diagnosed with a carcinoma of lung, and initially he was okay, but then he developed irrelevant speech. Then what? His sleep is disturbed. Morning it was okay, but night there is alteration in sleep and this irrelevant speech and all. And this developed 3 days back. Okay, that means it is an acute episode, right? So okay. So today's topic is delirium. The delirium is very important topic. You should know. Why? Because we used to see this symptom very frequently in palliative care. Okay, possibly the most common psychiatric morbidity, which is associated with acute medical illness. Okay, often it is underdiagnosed or misdiagnosed as a psychiatric symptom and often undertreated. So after this class, everyone should able to identify the delirium, the cause of delirium, how to manage delirium, okay, how to gate the patient and all, how to follow up the case. Okay, so how many of you have seen the delirium in your patients?
Dear participants, please respond.
So what is your experience? Can anyone share on experience you had?
Kindly respond.
How is it now? Is it okay? Whether the slides are visible now?
Yes, yes, ma'am.
Is it the same way as before or
Yes, yes,
it
yes, ma'am.
changed? Same, okay. Are you able to read the slide?
Yes, ma'am.
Yes, okay, then it's fine. Thank you. Thank you. Okay, I hope some of you may have experience treating delirium patient. What are the challenges that you have faced while managing delirium patient? Are you able to identify delirium so easily? Whether you had any confusion in diagnosing delirium with any other symptom or a disease? Okay, so the term delirium.
So, ma'am, they are responding in chat box. They are saying yes, ma'am.
Okay, responding in the chat box. Okay.
Them are facing some network issues. Okay, that.
Yes, okay.
But you
So
can
the term
put someone's name. They will respond.
delirium, the term delirium is derived from word delire, which is a Latin word which means to go off track. Okay. Delirium, what is happening in delirium? So there will be disturbance in attention and awareness, and it is usually acute in onset and it can fluctuate. Okay, and at least one additional disturbance in cognition means, and there will be evidence of underlying organic etiology or etiologies. I will explain this in coming slides. Okay, so why is delirium important? Why we are studying this delirium in palliative care? Because it is very common, and in medical patients, the percentage is 10 to 30%, and in ICU admitted patients, it is around 20 to 50%. In about 88% of patients in the end of life, we see delirium. Okay, and how does delirium occur? Actually, the exact pathophysiology is poorly understood. But there are many hypotheses like neuroinflammatory hypothesis, neuronal aging hypothesis, oxidative stress hypothesis, neurotransmitter deficiency hypothesis, diurnal dysregulation hypothesis, network disconnectivity hypothesis. And there is deficiency of acetylcholine and excess dopamine, which is seen in case of delirium. Okay, these are the pathophysiology. The exact the pathophysiology is unknown or poorly understood. Okay, so in delirium, when there is hypoxia or metabolic derangements, what can happen? There will be impairment of cerebral metabolism, which can result in the decreased synthesis and release of neurotransmitter. There will be some neurotransmitter imbalance that will result in the disruption of synaptic communication. And not only the hypoxemia, metabolic derangements, even drugs, which we are using commonly, can also cause this neurotransmitter imbalance. And some other hypothesis is systemic inflammation. We have seen here, right? Neuroinflammatory hypothesis, oxidative stress hypothesis, or neurotransmitter deficiency hypothesis. In neurotransmitter deficiency hypothesis, there is imbalance in the neurotransmitter release, which is resulting in delirium. In neuroinflammatory hypothesis, what is happening? Systemic inflammation. There will be release of the cytokines, interleukins, and all, and which will result in the activation of prime microglia, and this will result in the neurotransmitter imbalance and disruption of synaptic communication. Okay, which will result in delirium. These are some of the pathophysiology. Okay, now comes the main part. What are the causes of delirium? So, what is delirium? What are all the things that is happening in the delirium that you should know? There will be change in or disturbance in attention and awareness of a patient. Okay. For example, if you are seeing a patient during the daytime or during the morning rounds, he may be talking very nicely with you, conscious, oriented, and everything he's telling, answering very correctly, answering to the questions, and he's alert, he's very active. But the same patient can present with the delirium in the evening hours or even after an hour. If you see the same patient, there will be change in the cognition, in the attention they are giving, or the awareness they are having. Okay, awareness around the about the surrounding. If you are asking the time or how we can assess the delirium, we will see in the coming slides. So we are mainly focusing on the attention and awareness of the patient. Okay, so usually when we are seeing a patient, he should face us, he should answer us, he should ask us questions, and he should, most of the patient will be answering to our questions, and right. But for this patients, we all have seen patients with dementia. They have some memory deficit, right? Because of that, they may not be answering to our question. They may not be able to recollect everything. They may not be oriented around the oriented on time, place, person, and all. So all these things can happen in delirium, but this can happen all of a sudden. That means this delirium can be acute in onset. This point is very important, and also it can fluctuate even in a day. Okay. In the morning hours, he may be okay. The noon or after 1 hour or even after 10 minutes or 30 minutes, the situation can change. And again, it will fluctuate to a normal state, again to a delirious state. So this can happen. These fluctuations can happen all through the day. Okay. So these are very important. Okay, attention deficit and disturbance in attention awareness, and this can happen acute and it tends to fluctuate. So in most of the cases, there will be an underlying organic etiology or more than one etiology. Etiology means cause. Okay, there will be some cause. Okay, so what's the purpose of identifying cause? For every disease, for every symptom, there will be some cause, right? But if we identify the definite cause of delirium, if we are able to correct it or treat the cause itself, the delirium will improve. Okay, so this delirium is a reversible symptom if we identify the correct reason behind it. Okay, so why is it important? We have seen what are the pathophysiology, hypothesis and all we have seen. So what are the causes? These causes you should know because it's very important. Only if we know the causes, we can identify from each history. So D. This is a mnemonic delirium. D for drugs. E. Electrolyte imbalance. Hyponatremia, hypercalcemia. We have seen patients with hyponatremia presenting to us delirium or drowsiness or decreased speech, tiredness and all, right? So the same thing can happen here also. L means low oxygen state or insult. That means in MI, stroke, pulmonary embolism, in all these cases, what can happen? Low oxygen state hypoxemia can happen. We have seen in the hypothesis, right? In the hypoxemia, there will be neurotransmitter imbalance. There will be alteration in the metabolism. And I means infection. Okay. And R, reduced sensory input, visual and hearing. Then I, intracranial. That means any meds in the brain or due to some cerebrovascular accident or it can be due to any intracranial disorder or uncontrolled symptoms like constipation, urinary retention, pain. M for metabolic disturbances like hypoglycemia, hepatic or uremic encephalopathy, acid-base disturbances, etc. Okay, so what are the drugs which is precipitating delirium? Sedatives or hypnotics which we are using in palliative care like benzodiazepines, barbiturates, antihistamines can precipitate delirium. Anticholinergic drugs, oxybutynin, tricyclic antidepressants like amitriptyline, narcotic or opioids, which we are very commonly using in palliative care setting, right? And anti-Parkinsonian agents like dopamine agonist. Then also the delirium threshold is lowered in extremes of age. If a patient is having dementia, if a patient is having hearing or visual impairment, the delirium threshold will decrease. So the chance for getting delirium is more in elderly people with dementia and hearing and visual impairment. And also the alcohol abuse, depression, reduced physical activity, previous history of delirium, all these are factors that lowers the delirium threshold. And some of the triggering factors. What are the triggering factors? Change in environment, unfamiliar excessive stimuli, too hot or too cold, wet sheets, etc. And general deterioration, uncontrolled symptoms like pain, fecal impaction, urinary retention, infection, dehydration, hypoxia, anxiety, depression, all these can precipitate or trigger delirium. I will tell you some examples, okay, so that it will be clear for all of you. Sometimes patient can present you with pain abdomen. A CA or non-CA patient who is elderly, when a patient is coming to you with a severe pain, you should identify the pain, but he may not be conscious and oriented. He may be conscious, he or she may not be that much oriented. So you may not be able to identify or take proper assessment of pain. Where is the pain, where and all. But from the history, you may get idea that because of this pain, this happened all of a sudden, and the patient was completely normal 2 days or 3 days back, and then suddenly his pain got worsened, or he got pain previously, but that was not he was not getting complete relief of his pain with the current medication. He had sleep disturbance, and then he get into a state of disorientation. So here the patient is having pain as well as delirium. So one thing you should know is or undertreated pain can cause delirium. Why? The pain, if a patient is having pain, there can be sleeplessness. They will not be able to take proper feed. Okay, so the sleep itself is disturbed. In delirium, there can be alteration in sleep-wake cycle. We have seen one hypothesis related to all the diurnal variation in the sleep pattern also can precipitate delirium. Okay, another example is sometimes the patient may present with delirium or disoriented speech, but on history we can identify 7 days constipation history, or they can come with spurious diarrhea. I hope all of you know what is spurious diarrhea. Okay, there will be some history of long-standing constipation followed by diarrhea, right? So fecal impaction and urinary retention. Sometimes patient can present with catheter block, and the patient is also disoriented. So what is the reason behind the delirium? Exact reason can be urinary retention. Okay, and sometimes during infection, the patient can have disoriented speech and all. That is because of this infection which is precipitating the delirium. Once the infection is treated, once this cause is treated, they will get back to the normal state. Okay, even dehydration, if the patient is not taking food, if the patient is not taking enough water, that itself can precipitate what? Delirium. Okay. So if a patient is coming you with a history of delirium or disorientation all of a sudden, which happens all of a sudden, and that has a history of fluctuation all through the day, then you must try to identify any cause which can be treated, like pain, sleeplessness, constipation, urinary retention, spurious diarrhea, any infection, dehydration, any oxygen desaturation like hypoxia, anxiety, depression. Okay, and any change in environment. We have seen in ICU patients, this delirium is common. Why? There is change in environment. There is disturbance in their sleep pattern. Why? In ICUs, all time the light will be on and there will be some sounds in the background, beep sounds, and the doctors or nurses or will be coming every hour for monitoring the patient. So the sleep of the patient will be disturbed, right? All these can precipitate delirium in ICU setup. And unfamiliar excessive stimuli, bed sheets. If the patient is having urinary incontinence, or even a bed sore, which is not mentioned here, but even bed sore can precipitate delirium. Even a crumbs in the bed sheet, that still can precipitate delirium. Okay. So you should rule out all these causes. Okay, you should try to identify the causes. And narcotics you have seen, right? Narcotics, opioids. So we know delirium is one of the toxicity sign, right? So we should watch for delirium in patients patient who is on opioids and anticholinergic drugs, sedatives, hypnotics, anti-Parkinsonism agents. All these drugs can precipitate delirium. So the cause, you should be very thorough. After this session, you should not confuse regarding the cause. Okay, what are the cause? What are the causes which can precipitate delirium? Hyponatremia, hypocalcemia, low oxygen states, infection, reduced sensory input like visual and hearing disturbance. Sometimes the patient may have disorientation because they may not be able to hear you properly or see. Okay, urinary retention, constipation, hepatic, uremic encephalopathy, or renal failure and all. Urea creatinine values may be raised and which result in hepatic or uremic encephalopathy in hepatic failure and renal failure and all. In such cases, this metabolic disturbance can precipitate delirium. Okay. Is it clear till now? Is it clear till now?
Dear participants, please kindly respond now. Madam is asking. Otherwise, we have to take your name and call.
Is it clear? I want to know, or otherwise I have to repeat it because this cause and all.
Yes, ma'am, it is clear.
Okay, thank you. And triggering factors. I'm continuing with the triggering factors. Primary or secondary brain tumors. As we know, the brain tumors will definitely affect the functioning of the brain, right? So that can affect with cognition, that can affect the consciousness of the patient if it is affecting the corresponding area. And paraneoplastic syndromes, biochemical disturbance like hypercalcemia, hyponatremia, drug-induced withdrawal states like alcohol, nicotine, psychotropics, organ impairment, hepatic, renal, respiratory failure, and all sleep deprivation, surgery, trauma. In surgery and trauma, there is acute changes in their surrounding. There can be pain, right? And prodromal symptoms. How does it manifest? Okay, how you identify delirium? Even without asking the cognition and assessing the higher mental function, how we will get the symptom? They may be restless. What are the prodromal symptoms? They may be restless. There may be restlessness, irritability, sleep disturbance at the night, and altered sleep-wake cycle. So, if you are seeing the same patient for a long time, it is very easy to identify, right? There may be restless that day. When you are seeing the patient, they may not be able to concentrate on what you are asking for. They may be very irritated. They may not even lie down peacefully in the bed, or they may not sit properly. They will just want to get up, then sit down, or they may lie down and again sit up in the bed. Then again they will lie down, or they will just move around, or they will just pull out that catheter or diaper, or remove the clothes, or they may use some abusive words, or they will actually have some disoriented speech. They may not be able to identify you. Okay, every day when you enter the room and see the patient, they may be welcoming you, good morning doctor, or good morning sister, like that way. But on the day they are delirious, they may not be identifying you. Okay, or they may not even identifying their near ones. Sometimes the son is in the room taking care of the mother, but the mother may not identify the son. Okay, he may be in front of her, but the patient may be asking, where is my son? He went out, he will come now. Or they may not be oriented on the place they are on, like difficulty to identify where they are admitted, or where, sometimes they may talk like they are in the home. Okay, so they may be restless and very irritable, and there will be sleep disturbance at the night and all. And all these things can fluctuate during the daytime. That means 24 hours, in a 24 hours, these symptoms can fluctuate. How this fluctuate? For 1 hour, they may be okay, normal. In a very normal way, they will talk to you. But after 5 minutes, if you go and talk with the same person, they will, uh, they may be delirious. Okay. So this can happen during rounds and all. When we go and see the patient, he may be completely fine. And after 1 hour or 2 hours, when the sisters go for giving medicine, he may be delirious. Okay. They may report to us, but when we see the patient, we may not get the same exact thing. Okay, so this can fluctuate. And attention deficit. It's a hallmark, that means reduced attention span. Shift attention to new stimuli. They may not be able to focus on one thing or concentrate on one thing. So during the rounds or during the OP, when you are seeing the patient and asking about their symptoms and all, they may jump from one thing to another, or they may just move around. Okay, so disorganized thinking. Okay, they may not be able to think properly and give analytical, or uh, those things are affected. Okay, even the thought process will be affected. They may not be able to answer you to the question. Okay, their orientation will be completely affected. Okay, attention also will be get affected. And irrelevant speech. Okay, it can result in this irrelevant speech. Okay, when their cognition is affected, obviously they will get irrelevant speech. What are the features we can see? Increased or decreased psychomotor activity, like altered arousal, attempts to escape, remove medical devices. If you are putting cannula, or if you are putting ice tube on a patient on delirium, he will just pull it out. Okay. Or even if you are putting the cannula, he will just pick it up with the other hand. Bleeding can occur. So what we see usually in hospitals, they used to restrain them. Okay, tie with a cloth, or tying the both hands and all, restraining them. So we are not advising that. And affective symptoms like emotional instability, sadness, anger, fear. Okay, all these can be there. So agitation, noisy, aggressive behavior can be there. Altered perceptions like hallucination can also be a part of delirium. In all patients, there may not be hallucination, but it can happen. So just go through this slide. What are all the symptoms? In the previous slide also, attention deficit is there, disoriented speech is there, disorganized thinking, and anger, noisy, aggressive behavior, hallucination. Here you can see some picture similar to psychiatric illness, right? So it is common to misdiagnose delirium because of the symptom. Okay, because of the similarity of the symptoms with psychiatric illness, it is easy to misdiagnose this delirium. And sometimes doctors may refer this patient with delirium to psychiatric doctor. Okay, actually, in all cases, that is not needed. If we identify the cause of delirium and if we give the proper treatment, this delirium is reversible. So, how to identify? We will see. Okay, what are the core symptoms? Attention deficit, which will see in 97 to 100%, and thought process abnormality, disorientation, memory deficits, sleep cycle disturbance, motoric alterations, language disturbance. And non-core symptoms are perceptual disturbances, delusions, affective changes. So this is also very important. Like that, of course, the symptoms of delirium is very important. Then only you can identify. But if we see the symptom, attention deficit, thought process abnormality, all these can happen with many psychiatric illness also. So we should know. In depression, there may be memory deficit. In dementia, there may be memory deficit. In stroke patients, there may be thought process abnormality. Attention deficit may be there. And in patients with some other Parkinsonism, also there is associated dementia and thought process abnormality, attention deficit and all. Memory deficit may be there. Motoric alterations may be there. But language disturbance, but we should know how to differentiate it from other common psychiatric illness like dementia and depression. Okay, dementia actually it is a long-standing or chronic disease, right? It cannot happen all of a sudden. So you should take the history properly and you should get the idea from the family. If a patient is presenting you with a delirium, you may not be able to get the details from the patient because he is delirious, he is disoriented. So you have to get the details from the family, like when it has started. Okay, whether it is a chronic thing or it is an acute, whether there is any associated symptoms with this attention deficit, disorientation, sleep-wake cycle disturbance and all, like pain, constipation, urinary retention, decreased food intake. Why decreased food intake? Even dehydration can cause delirium. Even a bed sore can cause delirium. Even a change in environment, where there is any history of a recent hospital admission in the ICU, or even decreased food intake can cause hyponatremia, hypokalemia, and metabolic disturbance because of vomiting, loose stools, or any infection in the patient, any wound status in the patient, any drugs they are taking. Okay, so and whether it is fluctuating throughout the day. Okay, so we have to identify the cause. We have to identify whether it is a acute episode or a chronic episode. Okay, and types of delirium. Actually, there are 3 types: hyperactive, hypoactive, and mixed. From the name itself, you can identify. Hyperactive means what? Intense agitation, fearful, paranoid behaviors may be there. Mixed. Mixed means in between hyper and hypo. Hypo means calm. The patient may be very calm, quiet, and withdrawn. How? How you will identify this hypoactive delirium? Hyperactive is easy to identify, but the delirium which goes underdiagnosed is mostly hypoactive. Why? The patient may be very calm and he may be sitting quietly and he may not be very involved. Okay. So, if you are going for the rounds and if you are seeing a patient, he may not look into your eyes. Okay. He may look down or he may stare at somewhere. Okay. He may stare at somewhere or he may just pinch the clothes. Okay, he may just nod the head, but if you deeply take the history, you will be able to identify attention deficit, uh, cognition disturbances, memory deficit, and you can identify the other causes also. Okay, so hyperactive delirium, you should not miss hyperactive delirium after this session. There is one thing called hyperactive and hypoactive delirium. Hyperactive delirium is very easy to identify because of this intense agitation, restlessness. Patient may be shouting, or patient may be making unnecessary noise. They may not even lie down. Okay, some patients may jump or stand on the bed. Okay, sometimes the patient may run around their home. Okay, I have seen such patients. All these examples are from my experience, I am telling. Okay, they used to run around the home, or they may not. One patient will never sit, he will just uh, stand on the bed during the night time. Okay, then around the morning hours, he will go for sleep, and next day, he may not be able to recollect all these things also. And some other patient may present as hyperactive also. Okay, so hyperactive delirium, there will be restlessness, agitation, hypervigilance, hallucination, delusions, and all. More associated with drug intoxication, alcohol, or drug withdrawal. And hypoactive delirium is psychomotor retardation, lethargy, reduced awareness of surroundings. Hallucinations and delusions are less common in hypoactive delirium, more associated with hypoxia, metabolic disturbances, encephalopathy. Higher risk of death is associated with hypoactive delirium. Okay, the impact of delirium. Okay, so suppose a patient, if he is having delirium, what are all the things can happen? He may not be having proper awareness around his surrounding, about the surroundings. So there is more chance for falls, fractures, immobilization, decline. That will also, in this immobilization, falls, fractures can result in what? Declining the general condition of the patient itself, right? There can be incontinence, hydration, nutrition will be affected, emotional burden for the patient as well as the family members. Okay, the family members will be mostly affected if a patient is having delirium. Why? Maybe for the first time they are seeing a patient with delirium, and this happens all of a sudden. So he or she may be completely okay last days, and all of a sudden the patient is not identifying their near ones, dear ones, and all. So suppose you just imagine one situation, some of your close ones are having one disease, and suddenly he is not able to identify you. He may not be able to recollect your name. So how you will feel? Oh, I was doing all these things for them and he's not even identifying my name. Okay, and the emotional burden they have, like what is happening, what has happened to the patient, and is it a mental disorder? Is it a how to get back to the normal? Will it get reversed? All sorts of confusion they will have. So the management part, I will explain you how to deal the emotional status of the caregivers. Okay, we should address the family members also in delirium. Okay, why? Because the caregivers are the ones who is managing the um, patient, right? So since it is an acute episode and it is almost similar to the psychiatric illness. There will be some source of anxiety in the caregiver side also. So we have to address that also. Okay. And assessment tools, confusion assessment method, intensive care delirium screening checklist, cognitive test for delirium, abbreviated cognitive test for delirium, delirium detection score. There are many other scales which are available for assessing delirium. The most common and very easy method is confusion assessment method. What we are assessing here? We are assessing the attention of the patient. We are assessing the consciousness of the patient and the thinking ability of the patient. From this, we can get the idea of attention, orientation, their consciousness, what any memory deficit if it is there. Anything we can identify from this confusion assessment method, you can definitely follow this. So, what are the things we will focus on? Is there any evidence of acute change in mental state from patient baseline? Does the abnormal behavior come and go? That means fluctuation during the day, increase or decrease in severity, and attention. Does the patient have the difficulty to focus, become easily distracted, having difficulty keeping track of what is said? That means they may be jumping from one topic to another. Okay, there may not be any link between the things they are saying. Okay, he may be answering, yes, doctor, I am in the hospital. My son has brought me to the hospital, and I seen my friend today morning. He is in the airport now. We met in the airport. Like that way, they will talk. Okay. So they will jump from one thing to the other. Something will be normal way, but on the all of a sudden it will fluctuate. Okay. You have to track their conversation or the speech. Okay. And the presence of either feature C or D. Acute onset or fluctuating cause should be there, and inattention should be there, and any one of the two, like disorganized thinking or altered level of consciousness. How we will identify disorganized thinking? Is the patient's thinking disorganized or incoherent? For example, irrelevant conversation, like I have told you before, and unpredictable switching of subjects, unclear or illogical flow of ideas, and all. Altered level of consciousness. He may not be alert, or he may be hyper alert, like vigilant, lethargic, drowsy, but easily aroused, comatose, like that way. So I hope it's clear for all of you this confusion assessment method. We have to ask for acute or chronic onset of the duration of the episode. We have to ask any fluctuation in the course. We have to ask attention deficit, consciousness of the patient, and disorganized thinking status of the patient. We have to ask. Okay. Mimickers of delirium. So we have seen the symptoms, and from the symptoms we could identify that many symptoms are having this delirium. The symptoms which is seen in delirium has similarity to dementia, depression, and all. So how to differentiate? Dementia and depression is not acute. Okay, both of these are having a chronic progression or chronic in onset. Okay, it cannot happen all of a sudden, and it will not fluctuate also throughout the day. It cannot fluctuate. Once the dementia is there, the patient will have some memory deficit, but on long term, there can be some progression, the gradual progression for dementia. The same thing with depression also. And inattention. Inattention can be seen in all these things. And that is why we will get confusion between these diagnosis. And altered consciousness. Dementia, the patient may be conscious. Depression also, patient is conscious. But delirium, there will be alteration, altered consciousness. Sometimes they may be conscious, sometimes they may not be. Okay, in consciousness. Okay, alteration in consciousness. Disorganized thinking. In dementia and delirium, there will be disorganized thinking. In depression, the thinking ability of the patient is not acted because of their depression state or depression. They may be inattentive, they may seem drowsy, okay, they may seem very tired, but thinking and all will not be affected. And altered psychomotor activity, it can be seen in all these cases. Altered psychomotor activity, they may not be very active. Okay, and chronic duration. So delirium, once it is identified, if you are not able to identify the cause, and in some cases, even if we treat the cause, it can be chronic also. Okay, but mostly it is acute in onset. Okay, so history, physical examination, head to toe, assess hydration, nutrition, evidence of sepsis we have to see. Then investigations. Okay. Investigations like blood protein to rule out other causes of infection and all. We can use the blood protein and serum electrolytes, RFT, LFT. So in order to identify any electrolyte imbalances, excuse me, 1 minute. In RFT, there can be some derangement in the serum urea creatinine. In LFT, there can be some renal function abnormality, and even in hepatic encephalopathy and uremic encephalopathy or electrolyte imbalance can even result in encephalopathy, right? And in all these cases, the patients can present with delirium. Okay. So if we treat the underlying cause like renal failure, liver failure, or the electrolyte imbalance, the condition can worse also. But if the underlying cause like RFT, LFT, and electrolyte imbalance is not correctable, if it is not correctable, sometimes the patient may be in severe renal failure or liver failure. Urea and all may be above 100 or 150 or so. Creatinine may be raised. So in such cases, even it is not possible to reverse the cause. The cause is still there, right? So in such patients, we may not be able to completely treat delirium. Okay. So if there is aggression and all, we may have to manage with benzodiazepines and all. So we will see that in the management part. So management, correctable, non-pharmacological and pharmacological management. Correctable. So what is delirium? What are all the symptoms we see in delirium? There will be attention deficit, there will be fluctuation, there will be disorganized thinking or alteration in consciousness, right? What are all the things we can do to assess delirium? That all we have seen. What are all the causes we have to rule out while dealing with delirium? Is fecal impaction, pain, urinary retention, infections, dehydration, okay, any drugs which is precipitating this. So you just see all these cases, all these are correctable, right? Fecal impaction we can correct it with even digital evacuation or by giving enema or by regularizing a laxative. And pain, definitely we can manage pain according to the WHO analgesic ladder. Definitely we can treat infections, urinary retention and all. Dehydration and electrolyte imbalance if the patient is nearing end of life, DOL state. We won't actively intervene these electrolyte imbalance and dehydration. Why? The body itself is in a natural state of death. So their metabolism will get slowed down. So there is no point in actively correcting dehydration by putting an IV fluid and or putting rice tube. So you should know there is one thing called terminal delirium. So in such cases, there is what we focus on is we have to correct the correctable. We have to identify the cause. If we can correct it, we can do that. But whatever intervention or procedures management we are doing, it should give comfort care for the patient. We should focus on the comfort care rather than correcting the cause or correcting the delirium at any means. Okay, that is not the way we are dealing with the patients. Okay, and discontinue or alter drugs which precipitate delirium. And non-pharmacological management is optimize sleep wake pattern. How we can do that? If the patient is admitted in the hospital or even if they are at home, we can ask them to switch off the light after 9 or 10 p.m. and we can allow them to be in a peaceful or calm place. Okay, at night, can maintain that calmness in the IP ward or in the rooms or wherever they are. And we can, sometimes the patient may be anxious and they may not be sleeping properly. So we can ask what is the reason for their anxiousness. Sometimes they may not be anxious for sleeping alone. So if there is someone in the house to share the room, we can just change that. Okay, and reorient the patient. Okay, if they are not identifying your name or if they are not identifying their near ones, we can show some photos, we can show some albums and reorient them by saying the name. I am your daughter, my name is this, and you can ask them to repeat. And communication, clearly communicating what is happening around them. They may be in a different world, right? So we should clearly reorient the patient, like you are now admitted in so and so hospital. We are all with you. I am your son. Sometimes they may not even identify who are you. Okay, sometimes you may be the caregiver may be a relative or sometimes a friend or anyone. Okay, reoriented. You are doctor or you are a nurse. Your name is this, like that way. And communication. Okay, communication. You should talk with the patient. You should get them engaged throughout the day. Never let them to be alone. Okay, and encourage mobility. Ask them to or make them come out of the room. Okay, instead of being locked inside a room or a house, okay, get them out of the house or room itself and play some TV, videos, or movies, or whatever they like. Okay, so if they like to watch TV from the dear ones or from the caregivers, you will get an idea. Or from their close ones, you will get a clarity regarding what are all their wishes, likes and dislikes and all. So you can do that for them. Okay, playing music and giving them good food, monitor hydration and nutrition, giving the food they like. Okay, and monitor bowel and bladder function, provide support and education. This you have to give for the caregivers, provide support and education. Education, we may have to give the caregiver education, how to look after such patients, how to reorient them, how to do all these things. Okay, each step you have to explain to the caregivers. Okay, how to optimize sleep pattern, how to reorient, how to encourage mobility, on and everything. And daytime, for optimizing sleep wake pattern, we can increase the exposure to sunlight during the daytime and low level light and noise in the nighttime, and sleep protocols, massage, warm milk, and all these things can help. And even we can add melatonin tablet also we can to maintain that circadian rhythm. Okay, there will be alteration in the rhythm, so we can give the medications also to maintain the sleep wake cycle. And reorientation, explain where they are, who you are, what you are doing, whiteboard, visible clock and calendar. You can place a calendar and a clock where they can see in front of their eyes, in front of their bed. You can place some calendar so that they can identify the date, what is today's date, year, month, and everything they can see. And if they have some visual disturbances or hearing disturbances, you can correct that also. Okay, like getting ophthalmology consultation or in the consultation for them, and sometimes hearing aid and correcting the vision can help such patients. Okay, they may be disoriented because they are not knowing what is happening around them. Okay, they may not be hearing you properly. Okay, and visible clock so that they will get an idea about day and night. So communication, good sensory stimulation, eyeglass, hearing aids, dentures. Okay. Encourage mobility. Sit out of bed for meals if possible. Avoid using physical restraints as much as possible. Minimize use of catheters. If you can do all these things, it will be good. And assess urinary retention, constipation, fecal impaction. Okay. Physically restraining them. I used to see the patients with delirium. Most of the patients' hands will be tied around the bed, okay, or around the window side. So what we should do is we should remove all those things. We should tell them, we should start them on medication. We should identify the cause of delirium. We should correct the correctable causes. Okay. We should educate the family and give proper support for them. Then provide support and education. Okay. So, if the patient is in an aggressive state, highly restlessness state, you may need to admit the patient for treating. Or if your patient is admitted with the delirium, you have to explain what are all the things you are doing for the patient, and you have to involve the family also in the patient care and educate them and ask them to reassure the patient in a calm voice. Okay. And now comes the pharmacological management. Sometimes the family members may be very anxious, so you have to sit with them. Okay, sit with the family members. You may have to, you may know how to do the bad news breaking, right? Like that way, like the way you are doing bad news breaking, you may have to sit with the patient, you may have to hear them, hear their doubts, and you may have to give some time for the family members to ask you doubts, and you may have to explain what is happening to the patient. It is not a mental disorder. This is common, a symptom which is seen in the elderly and in old age and in patient who is undergoing all these medications or having medications. This alteration in consciousness and attention deficit can occur. The state is called delirium. In medical term, it is called delirium. Previously, it was known as psychosis. And so, what we are doing is we are trying to find out the cause. Usually, it is reversible. So, we are trying to find out the cause and we are treating it. We have to wait for some days and monitor the patient. Like that way, you have to counsel them. And you should definitely tell the caregiver that it is not a mental or psychiatric disorder. Okay, this is just a okay. Sometimes, in most of the cases, it is completely reversible. Okay. Pharmacological management. Non-pharmacological methods, if failed, patient is distressed, patient is a risk to themselves or others, or if the patient is agitated, we may have to start medications. Okay. What are all the medications? Haloperidol and quetiapine. Haloperidol is most commonly recommended drug in acute onset of delirium, 0.5 to 2 milligram every 2 to 12 hours. Can be given orally, subcutaneously, and IV 0.525 to 0.5 milligram in elderly. Maximum dose is 20 milligram in 24 hours and should watch for extrapyramidal symptoms. Quetiapine 12.5 to 100 milligram every 12 to 24 hours given orally, and sedating effect can help in patients with insomnia. Okay, so if a patient is having delirium due to sleeplessness, we can start quetiapine. Okay, then we may have to monitor the patient for some days. Then, if after correcting the cause, if it is reversing, we can stop these medications. Okay. So, what are all the other antipsychotics? Chlorpromazine, haloperidol, aripiprazole, olanzapine, risperidone, alone. So, we commonly use haloperidol and quetiapine. Okay. Maximum dose of haloperidol is 20. We may give 0.5 to 2 milligram once daily dose for patients with acute onset of delirium who is very agitated, whose management is not proper with non-pharmacological methods. If a patient is a risk to themselves or others, we need to start medications immediately. Or if the sleeplessness and all is causing delirium, quetiapine is very helpful because of its sedating effects. And benzodiazepines. Only for hyperactive delirium, we use benzodiazepines by in hyperactive delirium, patient is already lethargic and very calm, quiet. Why we are giving benzodiazepines? To calm down the patient. They are very restless, very agitated, irritated, and all. We give this benzodiazepines. Okay, to calm them down. Midazolam, which is very short acting, 1 to 2 milligram every 2 hours or SOS. Sub-Q and IV we can give. Maximum dose is 30 milligram over 24 hours. Lorazepam is 0.5 to 1 milligram every 2 to 4 hours. Okay. Can be given per orally, sublingually, or IV. Okay. Conclusions. Always correct the correctable. Do. We should identify the correctable cause. We should treat the cause. Go for non-pharmacological management as far as possible. A multidisciplinary approach may be needed if the patient is having any psychosocial disturbance. All those factors we have to assess. Okay. And always communicate and take the caregivers along. Identify hyperactive delirium and treat. We should not miss hyperactive delirium after this session. And okay. Pinch me. Look carefully for delirium, pain, infection, constipation, hydration, medication, environment. Then choose okay. So harness the power of the family and find or stop the culprits. Okay. Orient your patient and all. This is a sum of all the things that I have, summary of all the things that I have taken. Okay. So we can go through this also. Everyone please read by yourself. Okay. So there is any doubt you can ask. Thank you.
Dear participants, if you have any doubts, please ask. Ma'am is here to clear your doubts. Any doubts? Vinod Kumarji, Soma, Padma, Richen, Sonam. Having any doubts, everyone? Otherwise,
Like, I'm really sorry to say this. We are facing so many network issues. And because of that, we are not responding.
Sorry, I didn't get your question.
Am I audible now?
Yes.
Yeah, I'm in the middle of something, so here it's automation now. So most of the participants are facing some network issues, and maybe because of that they are not responding. So, um, and the number of participants are very less. So after the session, I'll check with them. If there are any doubts, I'll reach out. That's better, I think.
Okay. So this is the case scenario that I have started with. So now you go through this case scenario once again. 72-year-old woman with advanced cancer and was admitted to palliative care unit for symptom management. Previously, she was alert and oriented, but suddenly became restless. That means it's an acute onset and started having incoherent speech and had difficulty recognizing her daughter. Means there is difficulty in identifying orientation is affected, right? and she seemed frightened. So kept trying to get out of bed. She's restless, right? And was convinced there are strangers in the room. Or again, she's not that much oriented, hallucination. Okay. And her symptoms fluctuated throughout the day. Sometimes she appeared calm, but by evening there is fluctuation all through the day. Okay. Mostly the delirium get worsened during the evening and night hours, especially in the night hours. Okay. So the next scenario, carcinoma of lung on morphine for pain. Her caregivers reports to you patient frequently talks irrelevantly, but at times he's very clear. This irrelevant speech is not constant, it is fluctuating. Okay. Also said that patient is sleeping more in the morning hours compared to night. There is sleep disturbance at the night, right? The problems developed 3 days back. Okay. These are some of the examples. So I hope after this session you all will be able to look for delirium. You will not miss hypoactive delirium. And I hope you know the causes, the common causes like bed sore, constipation, infection, pain, urinary retention, catheter block, even dehydration, metabolic disturbances. Okay, and even some pathology like metastasis in the brain or some raised intracranial tension. All those things can also, even stroke patients will have some source of dementia or disorientation. So these are precipitating factors or the factors which lowers the threshold. If it is already present, again it can the patient will be more susceptible to have delirium. Okay. So thank you all of you.
Thank you, ma'am. Thank you so much. It's a wonderful session.
Thank you.
I think we can wind up this session.
Okay.
Thank you, everyone. Thank you for joining. We can wind up this session. Thank you so much.
Thank you all.